Good morning, or almost good afternoon. Okay. Hello, everyone. Buenos dias, Miami or Hollywood. Muchas gracias por acompañarnos hoy. Mi nombre es Sumaira y vivo con NMOSD. My name is Sumaira, everyone. Good morning. I have NMOSD. I'm also the founder and executive director of the Sumaira Foundation. Welcome to our final U.S. Patient Day of 2024. So happy to be here. The room feels a little sparse because apparently there was a pretty bad accident on the road. So there are people who are on their way. So of course, we want them to join us, but we also have to get onto our schedule. So I appreciate you all being here. These sessions are being recorded and will be available for replay, so anyone who does miss it can watch it after the fact. But just a very, very warm welcome to all of you. Thank you for being here on a Saturday where you could be doing anything else. But we have a very special day planned for you, a lot of great speakers and panelists, a lot of courageous patients who are going to be coming up and sharing their stories. Before we get started, I just wanted to say a quick thank you first and foremost to Dr. Flavia Nelson, Dr. Kotti Rammohan, who are our collaborators of this event from the University of Miami. They're having a fabulous CME event over next door that's continuing medical education. I do have to say we can't cross-pollinate patients and caregivers with that side of the event, so we have to do our best to stay on this side of the event. However, the restrooms are located there, so just weasel your way in and then weasel your way back when you have to use the restroom. So thank you to our collaborators. So happy to be here in Hollywood, Florida. Thank you to our sponsors, without whose support this would not be possible. So that's Amgen. They are our platinum sponsor. Thank you. Alexion Pharmaceuticals, and of course, Genentech. Thank you to the panelists and experts who will be joined by today, the patients, the caregivers, and the live audience who is here to listen and learn from all of these great sessions. And last but certainly not least, our TSF ambassadors. Raise your hand. We have 3 ambassadors here from Florida, Carla, Heather, and Nick. They represent the state of Florida. And then Jill Sharp, who is our chief of staff. Many of you guys know her. She's in the back there. She organized this entire event. And of course, Michael Devlin here. Raise your hand. He is a part of the foundation as well. Yep. So today is really for you. It's time to learn and understand more about our diseases. So don't be shy. As always, ask questions. There is no such thing as a dumb question ever. That's why we're all here, to listen and learn from each other. And make new friends. There's a lot of patients already in the room, but there are going to be more joining us hopefully soon. So, you have a community here. You're not alone in this journey of NMOSD or MOGAD. We will, of course, always be there for you from wherever we are in the world, but there's a lot of local love here too. So lean in and get to know each other. Just a quick poll. If this is your first time meeting another patient in real life, raise your hand. That's a big deal. That's a very big deal. I remember the first time I met a patient in real life, and it was truly a turning point for my diagnostic journey. So this is such a special moment for you, and I'm sure you'll remember it forever. So one last thing before we get started on our clinician panel. My message from me to you as a patient is to never let, if we can help it, our diseases or our diagnoses define us, consume us, or limit us. Our lives definitely look different with these diseases. I can speak for myself. Dreams and aspirations have drastically changed, but also so much good has come out of being diagnosed with this. I'm so grateful every day to be able to get up and do what I do and just have the life that I have. So I think it's important to be grateful even in times of despair, because there are so many gifts that come out of some of the worst times in our life. So that's just my message from me to you as a patient. And with that said, let's get started with our first panel. We are going to start with our clinician experts. So I'd like to call upon Dr. Jeff Bennett, Dr. Flavia Nelson, who I believe is next door, Dr. Maria Ortega, and Dr. Kotti Rammohan. Come on up. Melissa Ortega. I'm sorry. I'm so sorry. Okay.
Hi, I guess it's on. Hi, I'm Jeff Bennett. I'm from the University of Colorado. I am a neuro-ophthalmologist and neuroimmunologist, and in the clinic I see NMO, MOGAD, MS, and other neuroimmunologic disorders, as well as seeing patients with neuro-ophthalmic problems. And in the laboratory, my lab has studying what causes the pathology in NMOSD, MOGAD, and multiple sclerosis.
Thank you.
I'm Kotti Rammohan. I'm originally from India. Came to the United States in 1970, long time ago. And I am an internist and a neurologist, and trained at the National Institutes of Health in neuroimmunology and neurovirology, and was in the MS field since 1976, when there was no treatment for MS. And then treatments emerged for MS, and now treatments are emerging in NMOSD, and more treatments to come in MOGAD. Exciting times. And I retired once from Ohio State University, and I retired again from the University of Miami, and I just can't seem to let go because it's so exciting.
Thank you.
Hi, I'm Micheline McCarthy. I'm actually here to substitute for Dr. Nelson, who's giving a talk on MRI next door. But I'm a professor emerita of neurology at the University of Miami and had a long career in neuroimmunology and neurovirology that encompassed practices at both the university and the Veterans Administration. So I actually met my first NMO patient more than 2 decades ago she was a veteran, and unfortunately I wish she had lived longer because we didn't have what we have now to help treat the patients. So very happy to see all of this development and the support of the pharmaceutical companies and the ability of Suma to have a foundation to reach out to patients.
Hi, I'm Paige Kalika. I'm a little bit different. I'm actually a pediatric neurologist. So I'm an assistant professor at University of Miami, and I see patients there. And I see patients when they're admitted to, is this better? When they're admitted to Holtz. So I have the perspective of seeing these patients when they present very young. So I've had patients present with these conditions at 7 years of age, 9 years of age. So I have the privilege of following them and supporting them on the very start of their journey, at which point I eventually do transition them over to our amazing, amazing adult team, because we truly have the best team here, and I am so happy to be part of it.
Thank you.
Hi, I'm Melissa Ortega. I'm part of the team. I trained with Dr. Rammohan back in 2010 and been taking care of patients with NMOSD. We're based in the Boca location, so we're all part of one big team together.
Thank you all so much. So I like to start our days with this session because, here we're so lucky to have such a wealth of knowledge about our diseases here. So we're going to start with some basics, but understand testing, treatments, diagnosis, and then I want to open it up to the floor and have you guys ask questions too if you have them. So Dr. Bennett, why don't we start with you? Can you give us the 2024 definitions of NMOSD and MOGAD in the most layperson's way possible?
Well, that's tough. For the lay definition, I would say neuromyelitis optica spectrum disorder covers a group of disorders in which about 90% have had either isolated or recurrent optic neuritis and transverse myelitis. And 90% of those that I just mentioned are going to have the aquaporin 4 IgG antibody. And why that makes a difference is the available therapeutics that have been studied and proven to work for the treatment of those disorders, and the fact that we have ways to get those treatments paid for by insurance companies. Now, on the flip side, MOGAD is a disorder that can present with isolated or sometimes more rare recurrent optic neuritis, less common recurrent transverse myelitis, a mixture, and both of those conditions I'm not going to mention in the short answer can have a host of other very specific, unique presentations, but it's associated with the MOG IgG antibody. And that, by definition of the disorder, is 100% of individuals, although if you break it down into the scientific aspect, I doubt it's going to be true as we move more and more forward. We'll just get more sophisticated in our ways to test for the rare exceptions. And those are the big differences. And because we don't have approved therapies for that condition yet, for insurance companies to pay for, we do our best to try to treat with a variety of things I'm sure we'll get into later on.
Thank you. Dr. Rammohan, there's still a high percentage of misdiagnosis rate, unfortunately, in our community, and it's mostly multiple sclerosis. What would you say is the primary differences between MS versus NMO versus MOGAD?
So in the session that we just had on the other side, when we were talking to the physicians, the first talk that we had was about the fact that the last 20 years have been different. And the last 20 years have been different mainly because of the identification of a biomarker, aquaporin 4 antibody, and that has opened up a whole new era of treatment where all of you who have NMOSD, or most of you who have NMOSD, was at that time, prior to the discovery of this antibody, diagnosed as multiple sclerosis. And the distinction of identifying whether you have MS or neuromyelitis optica is a very crucial distinction, because a lot of the treatments that are given for multiple sclerosis can make a person with NMOSD worse. Majority of the treatments actually do that. And so that distinction became possible because of the discovery of this antibody. And like Jeff just said, if you have optic neuritis and or transverse myelitis, 90% of people will turn out to be positive for this antibody, and the availability of this antibody commercially has revolutionized the ability to distinguish who has MS and who has NMOSD. And that is also the reason why we now have FDA-approved treatments for this disorder, because we have been able to identify and separate these people from the MS population successfully. So we have now actually a more homogeneous group of people with identified problems that are unique, in whom we can give a specific treatment and identify a specific response. And that is from no treatment, all of a sudden in the span of 18 months, we had 3 approved treatments and more to come.
Great answer. I want to do a quick audience poll. For the patients in the room, raise your hand if you know which antibody you have. Okay. How many of you are aquaporin 4 positive? How about MOGAD? Okay. How many of you do not have an antibody, test negative for an antibody? Yeah. Okay, so there's 3 of us in here. Dr. Michelle, can you tell us about seronegative patients in terms of what is the prognosis for them, how are they cared for, and how often should we be getting retested for antibodies?
Well, actually, Dr. Bennett spoke on that earlier this morning. The patients who, the literature distinguishes patients who are double seronegative, which are the patients who have neither the aquaporin 4 antibody or the MOG antibody. these are a difficult group of patients. The seronegatives are a difficult group of patients to manage because you've heard about, of course, the available treatments, but they have primarily been shown to work in the seropositives. So Dr. Bennett is an expert on the pathogenesis and the distinctions in how the disease evolves when the different antibody is or is not present. I think that correct me if I'm wrong, Dr. Bennett, but you were retesting patients at least 6 months to see if antibody emerges, because sometimes it can emerge. And then the treatment is going to depend on the clinical presentation, whether it, looks like NMO, doesn't look like NMOSD or NMO. And that too, the treatment choice and the treatment monitoring is going to be much closer, much tighter. And I would also say that this is certainly true for all NMO positive patients, but even the antibody negative patients. The goal of treatment is to prevent relapse, because from the patient perspective, one of the things about this disorder, this group of disorders, is that relapses create the disability over time. And it is extremely important to prevent relapses, possibly even more so than it is in MS, because if you don't prevent the relapses, you're going to accumulate disability and your long-term prognosis isn't very good. Yeah. So if you are antibody negative, but even if you're antibody positive, close monitoring of your course, particularly early in your course after you've been diagnosed, is really important. And adherence to your medication regimen is really important. If you don't like what you're on and you're not sure that you believe in the medicine, please tell your physician, tell your care unit, your care family. Don't go off on your own and stop medicines because of the risk of relapse in the seronegatives as well as the seropositives. The risk of relapse is very, and its consequences are very severe.
Yeah. Do you want to add anything?
Well, when it comes to, for those who are seronegative, of which, you're not alone, we're here trying to investigate and figure out where you fall. For those who initially have gotten testing, and there were caveats about their care, perhaps you were on treatment at the time that your doctors first tested you, it's very important to get retested several months later, because treatments, especially in the acute setting, can make the relevant antibodies we talked about disappear. Now, with that being said, even if you retest negative and you say, yeah, I've been retested multiple times and I'm still negative, you're actually not alone. Mm-hmm. What we find is that only 5% of patients who initially test negative under good situations really show a new antibody emerge over time. So you're in good company of everybody else who's seronegative if you're repeatedly testing seronegative, and it's not about the tests themselves probably being deficient or special things about your care. It's that you're in a unique category that we hope we'll be finding your target as we get more sophisticated in terms of looking for what's causing these disorders.
So super rare within rare, yes.
No, I just wanted to say that testing should go beyond looking for aquaporin antibody or MOG antibody, because I can tell you we have seen other disorders that have been missed. A good example is a patient when I was on service was referred to us for plasmapheresis, who has been given steroids and was on a ventilator and got off the ventilator. And this patient had a condition called acute intermittent porphyria, which has got nothing to do with this condition, had normal MRIs, and when we recognized it, this is a condition in which the urine turns into a coke color when you just expose it to light. And that's exactly what she had, and she was sent to us as NMOSD for plasmapheresis. And so it's important to look for other disorders.
And on that point, actually, Dr. Delgado presented a case just a little while ago in the physician session of a patient who also had Sjogren's, wasn't it? Yeah.
Right.
And it's important to note that in the NMOSD world, including the MOGAD world, other autoimmune diseases can crop up and so the testing is important not only to rule out other autoimmune diseases, but possibly detect one, such as the case with Sjogren's. And that can influence your choice of medications as well. So it's important to be educated and ask the right questions and have the advocate for your health if you can't ask the questions, because these are very difficult disorders to detect, to diagnose, and manage, and they need everybody on the team, including the patients.
Absolutely. Thank you. Doctor, I'm sorry, I forgot your name. Paige. Okay. Let's switch topics a bit. Can you tell us about the breakdown of peds versus adults? So the onset, does it manifest differently? Is the prognosis different? So just differentiating between pediatric patients versus adults for both NMOSD and MOGAD.
So in pediatrics, we have kind of two different talks we give. The first talk is pediatric brains are not adult brains. They are very different. Kids are not little adults. We treat them differently. They respond differently. The brain is still developing and changing, myelination, and you'll always hear us talk about myelin and how important that is in all of these demyelinating conditions while that's still developing. So no, children are different than adults. On the other hand, pretty much all of our treatment strategies are predicated on adult evidence, at least at first, because what happens in the studies, in the real world, everything happens in the adult world. And they have the studies, they develop the treatments, and there are all these amazing new treatments. And then eventually they start to be used off-label in pediatrics, and then eventually we actually get our studies, and eventually maybe we even have some evidence to drive our strategies. But I was at a conference once where they referred to the great, gray zone of evidence-based medicine in pediatrics, and that's true for a lot of it. So what do we know about how these conditions present in pediatrics? They are rarer, certainly, which is good. I will say overall kids, in my experience, tend to do a bit better overall. Most of my patients who I'm following are actually doing great with their treatments. For NMO, they tend to, most often they tend to present with either the optic neuritis, the vision loss. I'd actually have to check my numbers, but at least you're always going to hear me differentiate between anecdote, which is things I personally have seen and heard, versus the evidence, which is what we've seen overall, what people have done studies on and reported. I tend to see more optic neuritis than anything else, even though I think transverse myelitis may be more common in the adult world. And the treatment strategies are pretty much the same, except I like to think of us as being, unfortunately, 5 to 10 years behind, because that's where our evidence is, and also that's where we are in terms of getting things approved in pediatrics. For MOGAD, this is actually pretty rare in pediatrics. I do have a few patients I've picked up over time. Of course, my patients always tend to have interesting presentations, for that at least. I've had children present actually with these odd kind of spinal presentations. What I've read, although I have not, so what the evidence shows is that some children actually will present with more of an encephalopathic picture with seizures and mental status changes. That one I haven't seen quite as much, but that tends to be rarer, I think. But again, the treatment tends to be driven mostly by what we've picked up from our adult colleagues. And in general, again, these kids seem to do well over time, but so I try to be very reassuring for my families, because of course as parents, doctors, nurses, clinicians, we want the best for our kids. We want to know that our kids are going to be okay. And kids tend to be very resilient. Even if kids do end up with residual deficits, they have their attacks and they don't get all the way better. They're amazingly resilient. The patient I've been following for the longest period of time, I think I saw her, my goodness, maybe she was 7 when she was initially presented. She has NMO. She presented with a very severe optic neuritis. She was transferred to us for plasmapheresis. She never really regained vision in that one eye, but she's about to turn 17 now. She's out there playing basketball, straight A student, amazing, amazing young woman out to take on the world. And, you know, that gives me hope. On the other hand, which is always in the back of my mind, well, these are people who are starting their disease burden early. So I don't know what they're going to look like in 10, 20, 30, 40, 50 years, but what I do know is that with the state of research, with all of these amazing new diagnostic possibilities, treatment possibilities coming out, and again, eventually trickling down to me in pediatrics, but more importantly, the children are aging into in the adult world, I have so much hope for them, and I think that many of them will do very well.
Thank you. Dr. Ortega, oh yes, of course.
Just wanted to add, the journey for a pediatric patient can be sometimes a little long. And I see the parents here, so I don't want to call on you, but the treatments are just becoming available for pediatric patients. And the parents of the child that we are taking care of in the ravulizumab trial, the whole trial worldwide is 12 patients.
Wow.
And so far, the first patient was enrolled from Korea, the second patient from Japan, and the third patient, so far only enrolled 3, and the third patient is from the University of Miami. And the parents are sitting here.
That's incredible.
And we are eternally grateful to you.
Yeah, you're part of history. You're part of making this possible for other patients.
Yes.
I do think we need to give a round of applause for the parents and the caregivers, because these diseases affect everyone in our family, and so much falls on those who love and care for us.
We
So
truly appreciate it.
Absolutely. Thank you. Dr. Ortega, you're very fortunate to work in a place where there's so much diversity. So I'm sure you see patients from, all different colors, shapes, sizes, and whatnot. Can you speak to the demographics of NMOSD and MOGAD? Obviously it can affect anyone, but the prevalence tends to be more in certain groups of people from what we understand. So if you could just speak a little bit about that.
So yes, that's correct. Anybody can get it, and we certainly see all types of people who've been affected by either disease. NMOSD seropositive NMO specifically tends to, as opposed to MOGAD, where MOGAD is more 50-50 men and women, NMOSD is more, women are more often affected than men. And then there are some ethnic and racial differences, and how the disease can also present. Sometimes can be more aggressive in one group. Especially with NMOSD, sometimes we see more aggressive disease with African Americans and Hispanics as well. But every person, I'm a big believer that medicine has to really be individualized, and we can look at big studies and review the literature, but ultimately it doesn't really matter if you give any patient a percentage, because it only matters how that one particular patient's disease is moving along. And so each person has to be looked at individually, and care has to be individualized. It's not a one-size-fits-all, regardless of what treatments we have or even testing that we have. But I think that it's really important that you're followed closely by your provider, and I think that it's also really important to have a whole team that involves multi-specialties, therapists, both physical therapists and mental health therapists, and have the family involved as well. So regardless of whatever background you come from, and hopefully all your providers help to coordinate that as best that you can.
Thank you. Dr. Bennett, can you share what a typical workup for a newly diagnosed patient looks like? So what tests are involved, what imaging and labs and whatnot?
Well, obviously it's going to be based on the patient's presentation, especially when someone comes in with new optic neuritis we're worried about, number one, what that vision loss is. Is it severe? Is it in the mild range? And unfortunately, the severity doesn't help us differentiate much MOGAD from NMOSD because they both tend to cause severe vision loss. But when thinking about multiple sclerosis, we know that MS is less likely to cause severe vision loss. So already we have one hint. A good eye exam is important. I'd hate to say from being a neurologist that doesn't necessarily mean by your neurologist, but from a good ophthalmologic exam is also important because the characteristic of the appearance of the optic nerve can favor MOGAD over NMOSD, and that can lead to a much quicker diagnosis. And as we look at the next step, which is imaging, it isn't just a brain MRI scan, because the brain MRI scan doesn't get the optic nerve imaged as well as it should, and therefore an additional orbital MRI scan, sometimes called a face MRI at other institutions, can give us much more detailed look, and that MRI imaging can help determine what is more favored. Does it look more like MS optic neuritis, MOGAD optic neuritis, NMO optic neuritis? And so more time is needed in the machine as well. Doing a brain MRI scan is important for all conditions, whether you had spinal cord or optic nerve affected, because there can be other looks to the brain MRI scan that can favor MOGAD versus NMO, which are rarer brain lesion diagnoses, as well as MS, which is in that broader differential diagnosis. And finally, spinal cord imaging. When you have an attack of myelitis or effects of inflammation of the spinal cord, you're obviously going to get that image done. But it's important when other presentations to make sure there aren't silent lesions, which can happen in up to 30% of individuals that may give a hint on that diagnosis. Spinal fluid analysis can also be important, and particularly, as we've talked about seronegative disease, about 10% of MOGAD patients can have isolated MOG antibody in the spinal fluid alone, and that is present more often with transverse myelitis than with optic neuritis, but can be a key, especially if the blood testing, which we'll get for obviously these reasons, aquaporin 4 antibody and MOG antibody, are also important. Additional blood tests can be helpful, and looking for signs of other autoimmunities that could be masquerading as any of these. As has been said before, you don't know it as a patient, but at the bottom of all these diagnostic criteria is that small thing you see in your real life. Please read the fine print in detail, which says, "No other better explanation," is at the bottom of each of those diagnostic criteria. So, there's going to be a broad workup across these different categories. That's going to mean a lot of time. And yes, the antibody, when it comes to aquaporin 4 Ig, is very specific. If you have it, you have the disease. MOG antibody can have some misleading positives, and once you get into the seronegative category, even though you have what's limited to an NMOSD presentation, needs a very careful, extensive workup looking for other possibilities. And so with each individual case, there's going to be differences, but there is a broad, long road ahead that, based on the current circumstances, you may be treated with the best possible guess because of the severity of presentation in the meantime, which is often steroids and or plasma exchange based on the severity.
Thank you. Okay, so now we're going to talk about the big R word, which none of us like, which is relapse. Dr. Rammohan, can you talk to us about relapse versus pseudo-relapse, and what are things we as patients can do? Like, what are some tips to prevent relapses, if at all?
So, from a patient's standpoint, there is no distinction as I have relapse or I have pseudo-relapse. all they know is that I have a new problem or I have worsening of an old problem. And if that happens, it is imperative that you seek help and let the healthcare professionals sort out whether what you have is a relapse or a pseudo-relapse. So let's talk about what each of those things mean. A relapse is an actual new injury that is happening to the nervous system, whether it is the optic nerve or whether it's a spinal cord or a part of the brain. And that is caused by, as we know, in aquaporin 4 positive patients, the presence of the offending antibody that has gained access into the brain and spinal cord or optic nerve and attaches to the particular cell, which is in this case an astrocyte, and has activated a thing called the complement, and the complement sets off these injuries that then cause destructive changes in the location where this antibody has attached to the astrocyte. And that is a real relapse. And all of these things that we talk about, optic neuritis, which is a term for loss of vision, transverse myelitis, which is difficulties with the spinal cord, whether it is motor, sensory, bladder, bowel, whatever, or parts of the brain which are known to be involved in this disorder, where the area postrema syndrome can be completely daunting because the patient ends up in a gastroenterologist and sometimes has a gallbladder taken out because somebody says that this problem was due to a gastrointestinal problem, and in fact it all along was a brain problem, and some of you are familiar with that happening. And that's a whole spectrum of what the relapse is. Now, what is a pseudo-relapse? A pseudo-relapse is where there is no new injury to the nervous system, but for whatever reason, a decompensation occurred that resulted in some of the old symptoms, recrudescence, coming back. And it may even be a new symptom that was held in check unaware to you that became apparent because of whether it was a urinary tract infection that set off the balance, that resulted in a fever, and patients with NMO, just like MS patients, can do poorly when your body temperature goes up. And I've heard people say, oh, when your body temperature goes up, your nerve stops conducting. It's not that the nerves stop conducting. The nerves speed up conduction when the body temperature goes up. And speeding up conduction is one of the bad things you can do when you don't have myelin in areas where the axon is still intact but the myelin is gone, because you don't have the nodal safety. The safety drops when you speed up nerve conduction because less channels depolarize. And that can lead to new attacks or worsening of the old symptoms, which is completely reversible when the offending agent is taken care of. In the case of a urinary tract infection, identifying that the problem was a UTI and treating the UTI and treating the temperature is really what takes care of it. There are other situations that somebody may have had a surgical procedure done, and in the post-operative phase, you get into issues related to this. So, I tell my patients, if you're going to have an elective surgery, do alert your anesthesiologist that you may not come out of anesthesia as quickly as somebody else, and you may have some residual issues, and it may take a day or two for you to quite get back to where you were. And those are the pseudo-relapses part of it. So from a patient standpoint, you don't say, oh, I have a pseudo-relapse when you have a problem. No, you go and see a healthcare professional. And even emergency rooms are aware of these situations now. And sometimes you get treated with steroids when you don't need to get steroid, but that's a different issue.
Thank you. Okay, we have about 8 minutes left, so I want to make sure we cover a very important topic, which is treatments. I didn't have the chance to do my introduction the way I wanted to this morning, but I have been living with this for 10 years. And when I got diagnosed 10 years ago, it was a very different sort of prognosis. There was no treatments available. Obviously, everything looked very bleak, and everything you saw on the internet said that you were going to die within 5 years. Unfortunately, that information still exists on the internet, which we need to find a way to get that off because it's not necessarily true. And I think, what I have seen, at least from my vantage point as a patient and an advocate over the last 10 years, is how drastically things have changed for NMOSD patients and MOGAD. For NMOSD patients, we went from having 0 FDA-approved therapies to now 4. And these are 4 treatments that actually work. And they were designed for patients like us. And that has dramatically sort of changed the outlook of NMOSD. And for MOGAD, we now have ongoing clinical trials, which means in a few years, we also may have FDA-approved therapies for MOGAD. And if you didn't know, 95% of rare diseases actually don't have a therapy at all. So NMOSD and MOGAD are very fortunate to be these rare diseases where we already now have treatments or are going to have treatments, but even more so, what a luxury to have options for treatments. So I want to ask the panelists, we'll start with the ladies, how has the availability of these FDA-approved treatments and, of course, the clinical trials for MOGAD changed your practice and how you look at NMOSD and MOGAD patients?
Well, I should say that a lot of my practice was in the Veterans Administration. And I just want to share briefly that in the VA, if a drug is approved, then the VA must provide it.
Awesome.
Now, they have a complicated pharmacy benefits management system, but my experience was that it worked well. It just took a little bit of time. And so I can't emphasize enough the importance of getting drugs tested and approved, because then organizations like the VA, or even Medicare for that matter, although this is a different age group, will be in a situation where they have to provide the drug. And so from the patient that I lost was a veteran, a lovely woman. She had just retired from her military service when she had her first attack. And as you pointed out, so we didn't have anything to offer. So it's really important to try to get get these drugs tested and approved. Takes a lot of patient advocacy to do that too. You have 4, wouldn't you like to have 6? And especially for the MOGAD, the seronegatives that Dr. Bennett is studying, to have more options there. So I would say that from the point of view of that type of managed care system, the Veterans Administration, having the FDA-approved drugs makes a big difference, makes all the difference.
We have 3 minutes on the clock, so I don't want to rush you, but I would love to hear from you.
So I think it's a time of a lot of hope, and that's exciting for all of us. And in addition to the FDA-approved treatments, because we have been studying these diseases for a longer period of time, we have some decent, less robust observational studies with off-label treatments as well. Mm-hmm. So it just gives us more option, because you never know what your particular body's going to tolerate, how you're going to do. So we have more options, both FDA-approved and even off-label drugs that we can use. So I think, like I said, I think it's a time of hope, and we're recognizing the diseases earlier so that we can treat acute attacks and then hopefully continue to prevent attacks as much as possible.
What about for children?
No, children are always, that's why I was waiting for you ladies to speak, because then I'm going to say, well, in pediatrics, we do what the adults do, just more slowly. Luckily, steroids have been the mainstay of treatment of pretty much everything in pediatrics for decades upon decades, so I don't have any trouble with those, and those are very, very effective for our acute attacks. I will say that for maintenance, I'm much more limited, unfortunately, but I'm a big fan of good old-fashioned rituximab. My NMOSD patients have actually done very, very well on it. They tolerate it very well. My hardest part for them is, convincing them to come in because you need your treatment already. I know you feel great, but I don't want to relapse already, okay? So that's my hardest part, convincing them that they need the medication even though they feel well.
Have you had any experience, since there are multiple drugs now, the pharmacy hierarchy that many insurance companies employ? So you have to try drug 1, drug 2. Dr. Bennett, do you see that, or Dr. Rammohan, do you see that yet? In these, we're just to the point now where we have multiple choice, but.
Yeah, I think one of the things that we had hoped when drugs were approved for a rare disease is that there is no qualification by insurance companies about what you have to take first in order to fail to get another access to another drug, because it's such a rare population that the bottom line in their registry is not as impactful, and therefore it's just a matter of using an approved therapy. No, it didn't happen, and there are deals that we don't understand between, or not disclose between, pharmaceutical companies and insurers, such that with a better payment issue for, or cost for certain drugs, there's a preference. And what I want you to know is that if in discussion with your therapy, you and your caretaker have decided on an approach that best fits you and your needs and is approved, there are ways to work with your care provider to get around those issues. But it is a real problem, and I encounter it on many occasions in Colorado with the various insurers that are there.
I just wanted to end up with saying that there is absolutely no excuse for somebody to be not be on drug, because even if the insurance company says no, the pharmaceutical companies will give you drug. And so to say that I couldn't get it because my insurance denied it, don't do that, because you can get drug from all these pharmas. They provide free drug. And so, it is absolutely imperative that you pursue the right therapy for you, even if the insurance says no.
And for the MOGAD patients, getting enrolled in a clinical trial means getting free therapy and care. So that's another way to get on treatment. So just one message to the live audience here. The pharmaceutical companies are actually here, and they have patient education materials about their therapies out in the hallway. So I encourage you to meet with them, collect all of their collateral and decide for yourself with your doctors about which treatment, if you wanted to switch from whatever you're on now to something else, or if you want to get on something new. Shared decision making is something that we're very passionate about here at the foundation, but there's an abundance of information out there. People, lean in and learn more and figure out what's best for you, not what insurance thinks is best for you. So on that note, I do want to allow maybe a couple of questions from the audience. Does anyone have any questions for the doctors? Yeah, right here.
Thank you so much. Thank you for everybody for being here. Today is a great day. I always say to my friends that my heroes are neurologists and baseball players. So thank you guys for being here. My question is regarding the so much information, especially to make a decision on a diagnosis. Have you seen advances with artificial intelligence, like interpreting all that information that can help you guys make a better decision?
That's such a good question. Who wants to take it?
Well, there's a lot of work going on in AI right now to help with that decision making, particularly in looking at the back of the eye. Can we look at someone's back of the eye with the help of AI to differentiate whether a case is more likely MOG or more likely aquaportin 4, NMOSD, or multiple sclerosis just by a simple fundoscopic examination? And similar studies are going on in radiology for that. But I think that as liberal as those tests are used, it may not be as impactful for the ultimate diagnosis as it is for driving acute therapy in situations in which time is vision, of which time is neurologic function, and getting the right aggressive approach to an attack is coming in. But yes, our jobs are threatened by AI, just like other people's.
We have a question.
Good morning.
Hi.
Just want to say we have two heroes in our life, Dr. Ruben Bromberg, who diagnosed after 37 doctors knew absolutely not a clue what was going on with our daughters. He diagnosed, and Dr. Kotti Rammohan, who treats our daughter and is amazing. We love them both. Dr. Rammohan, if you could just say a few words of the treatment that we're going through and how it's impacting pediatric lives. And number two, and this is, I share this with Dr. Rammohan, my frustration, and how do we get the word out to other caregivers? Because every time we go to a doctor or like a dentist, recently we had a dental appointment, the dentist was almost afraid to touch her because had no clue what NMOSD was, or every time we go to the pediatrics office, you know, if you don't get the main doctor, you get one of the assistants, they have no clue. How do we get the word out about this disease and that, you know, it's okay to treat your patient? You don't have to treat them with kid gloves just because they have NMOSD.
Wow, great question. Go ahead.
So I did reach out to your doctor to see if they could come for this conference, and I don't know if she's in the audience. If she is, she has not introduced herself, but this is a problem, and that's the reason why we are having these conferences, because physicians need to be educated just like we all need to be educated. We try to learn and then to teach, and so every year we hope that we'll be able to have these conferences where more and more people can be educated. For example, one of the frustrations that you voiced to me is the treatment that she's on, needs that she is on meningococcal vaccine, and people are saying she doesn't need it. That's, they don't understand that there is a specific reason why we are asking for that immunization. And to say, well, you don't need that, it's wrong, and people need to be educated about that. And the only way we can circumvent that is if they're willing to come for these meetings. And I think it's important that people come for these meetings. And
we are trying to promote education in the medical schools and in residency training, and at UM. The UM division has a program that includes this kind of thing, that is teaching about NMOSD and MOG and all, and it reaches down into the medical student level. So hopefully that generation will be out there practicing pretty soon. But we've talked a lot with the pharmaceutical representatives this morning about the importance of education, and meetings like this, your work are going to make the difference in the long run. You are probably the biggest advocates of education that there are, but it can be tough, can it? You go to the doctor and they don't know what you're talking about. Yeah.
When I talked to you about this conference, I was hoping you'll come. And very glad to see you here. Yes.
I will.
Takes a lot of courage.
Yeah, go ahead.
No, I was just going to say that, so before I did neurology, I did a full pediatrics residency, and I definitely think we need more outreach to the general pediatric population, because I remember the very first time I heard of this NMO thing, and I was doing my first year of neurology. In pediatrics, we talked about other autoimmune conditions, we talked a bit about MS, but I've been thinking about it all morning, actually, because I'm here. And I remember learning about it for the very first time, and I was already a fellow in neurology. I was doing my adult year. So I do think that some outreach to general pediatrics, primary care in general, would probably be very beneficial, because the knowledge, this is knowledge that exists that can be shared. And I tell my families all the time, medicine is a team sport. There's no one person running the show. We're all there crewing the ship together, and sometimes it's going to be one person at the wheel and sometimes another. But we all need to be on the same page. We all need to have education. And also, Dr. Bromberg is fantastic. Mm-hmm. You are in excellent hands with him also.
Okay, we have one more burning question, and then we're going to move on to the next session. Go ahead. Introduce yourself.
Hi, my name is Nick. I am Ambassador of Florida for the Samara Foundation. Is it not on? Okay. have you seen patients that are seronegative, that with them being on B-cell therapy reflect the testing of seronegativity?
So,
Yeah, I couldn't
Yeah.
hear you.
no, it was a question about whether being on B-cell therapy could affect the diagnosis of seronegative disease. And if I was seeing you 6, 7 years into it, no one had tested you, beforehand or just originally, yeah, there's a possibility that being on prolonged B-cell therapy with its chance to reduce the amount of circulating IgG or immunoglobulin could result in seronegativity. In fact, I have taken care, and I would say about upwards of 10% of my long-term B-cell therapy treated aquaporin 4 IgG positive NMOSD patients have lost their antibody after long-term treatment. There's many that haven't as well, the other 90% of them, and it similarly could happen for MOGAD-treated patients. And it is a possibility. It's rarely a short-term possibility unless that amount of antibody you had very early on in disease was low, what we call low titer, but it is a confounding part, and your caretaker will have to take care of that, considering that in the situation about retesting you and then thinking about how you presented and what you most look like to consider what the best therapy is moving forward.
And Dr. Bennett, you talked earlier this morning about how you can use both the ELISA and the cell-based, so you can test in 2 different ways for antibody to try to be more complete, maybe more sensitive.
All right. Well, that's all the time we have with these wonderful panelists. Please join me in thanking them for their time and their expertise. Thank you so much. We're so lucky to have you all here.